Hello everyone. Today in this video I am going to tell you the details of coordination and the abnormal movements. This is the last part of the motor system examination. I have already explained about the bulk, posture, tone, power, DTR, superficial reflex and the gait in this YouTube channel. Abnormal movements, also known as the involuntary movements, movement disorder, or it is because of the lesion in the basal ganglia or extrapyramidal tract. That's why known as the extrapyramidal disorders. Movements disorders are caused by lesion in the basal ganglia, and the structure included in basal ganglia are caudate, putamen, globus pallidus, combinedly say as a stratum or corpus stratum with substantia nigra and subthalamic nucleus. And basal ganglia is the part of extrapyramidal system. So other than the basal ganglia, thalamus, red nucleus and tegmentum of midbrain, reticular formation, inferior nucleus and vestibular nucleus are also included in extrapyramidal system. So broadly, group A center and group B center are included in extrapyramidal system. So in group A center, there are structure of the basal ganglia are included, while in the group B, other structure as red nucleus, reticular formation, olivary nucleus and vestibular nucleus. There are various pathway which connect the either directly from the cortex to the group B center or the from cortex to the basal ganglia, then from basal ganglia to the other structure in group B center. So combinedly, group A and group B center, in which all these structures are included, considered as an extrapyramidal system. Abnormal involuntary movement are categorized either hyperkinetic movement disorder or hypokinetic movement disorder. So in hyperkinetic, either chorea, balismus, dystonia, there are various movement disorders. In hypokinetic, example resting tremor, which is seen in the Parkinson disease. So today I am going to tell you the details of all these movement disorders, in which athetosis, balismus, chorea, dystonia, myoclonus, tics and tremors are included. So to remember all these movements, there is a trick: A, B, C, D, might, T, 2. So A for athetosis, B for balismus, C for chorea, D for dystonia, M for myoclonus and T2 for tics and tremors. Now the most important part of this presentation is how to differentiate all the involuntary movements. So whenever we are seeing a patient with the abnormal movement, we have to look which part of the body is involved. So the location, then the distribution. Is the proximal muscle or joint are involved, or the distal muscles or joints are involved? Then we have to check the rhythmicity, then rate, speed or frequency, then amplitude and the force, then relationship to the posture activity either during the sleep or not, and then is it exaggerated with the emotions and the temperature. So this will give us the clue about the which type of abnormal involuntary movement is this. So now I will explain all the abnormal movements one by one. So first, tremors. To define the tremors, we can say these are the purposeless involuntary movements. These are rhythmic oscillatory movements. And according to all these points, we can say it involves the distal parts of the upper extremities generally. But rarely it can also involve the arm, feet, eyelids, jaw or tongue. But commonly it involves the hands and fingers. There is one example of fine eyelid tremors as seen in the hyperthyroid patient known as Rosenbach sign. According to distribution, it involves the distal groups of the muscle and distal joints. These are the rhythmic, oscillatory movements, and the frequency can vary from the slow to fast. It can be between 3 to 5 Hz. We label as a slow tremor. It can be fast between 10 to 20 Hz, and force can also vary. It can be fine tremor as seen in the hyperthyroid patient. It can be coarse as seen in the Wilson disease, or it can be medium force. And we have to check the relationship to the activity. If it is during the resting, we label as a resting tremor as seen in the Parkinson disease. If it is associated with the activity, we will label as a action tremor. There are various other type of the action tremor. We will explain in next slide. Now how to examine for the tremors. So for the fine tremors, sometimes it is not visible with the resting position. So we have to tell the child to outstretch the hands. In this picture you can see, if it is still not visible, then we have to keep the piece of paper over the dorsum of both hands. So the fine tremors will be easily visible. This is the way to demonstrate how to elicit for the tremors. Now the types of tremors, it can be resting or static tremor as I said previously, or it can be action tremor. So the example of resting tremors is Parkinson disease, also known as akinetic rigid syndrome, in which patient will have the characteristic pill rolling movements, and it is seen in the adults, not in the pediatric patients, because this is the disease of adults. So now there are various subtypes of the action tremor. It will be visible when the child will do some kind of activity. It will not be visible in resting state. So what are the various subtypes of the action tremor? It can be intention or kinetic tremor as in the cerebellar disease, multiple sclerosis. These are the low frequency tremor. Wing beating tremors seen in the Wilson disease. These are the coarse tremor. And in this, the proximal part of the upper extremities generally involved, and these are the slow high amplitudes up and down movements. And for eliciting the wing beating type of tremor, we have to tell the child to hold the arm with the shoulder abducted and elbow flexed, and the characteristic wing beating type of the tremors will be visible. Another is the essential tremors, also known as physiological or exaggerated physiological. It is seen in the old age, labeled as a senile tremors. And rubral tremors are visible because of the lesion in cerebellar outflow or midbrain lesions. Orthostatic tremors will be visible when the child will stand, also known as shaky leg syndromes. It will not be visible in resting stage or when the child is sitting or lying down. So these are the visible when the child will stand. Neuropathic tremors seen in the peripheral neuropathy, and non-organic or psychogenic tremors. If you are not able to find out any etiology, then you have to rule out any stress or any tension are associated with the tremors. So all these are the various subtypes of the action tremors. There are various drugs which can also lead to the tremors. If you are not able to find out any etiology, then ask the detailed drug history. Example, sometime patient is having the addiction with the alcohol, nicotine, caffeine, amphetamine or aminophylline drugs can also lead to this. Antibiotic, example, aminoglycosides. And anticholinergic, antihistaminic overuse can also lead to the tremor. Diazepam, other antidepressants, SSRI, lithium, thyroxine, even anticonvulsant, which we are generally using in the seizure disorder, example phenytoin, valproate, can also lead to the tremors. Now the another abnormal movement is the chorea. To define the chorea, it is the involuntary, irregular, non-rhythmic, purposeless and hyperkinetic. It is rapid, jerky, unsustained movement. So according to all these points, it involves the one extremities generally. If half of the body is involved, we label as a hemichorea, and sometimes it is generalized also. Commonly involve the distal parts of the upper extremities, rarely proximal parts, lower limb, face, trunk, lips, tongue, even the vocal cords can also be involved. It is non-rhythmic and irregular movements, while the tremors are rhythmic, regular. And according to the rate, it is fast, abrupt, brief, rapid, jerky, and unsustained movement. And with the resting stage, it can be present in rest or even during the action, but it disappear with the sleep. So whenever patient will be in sleeping stage, chorea will disappear. There are various tests to elicit the chorea. Example, milkmaid grip, spooning, hyperpronation, darting tongue, piano playing movement. So in this image you can see I am performing the milkmaid grip. So for this we have to tell the child to hold the finger, and child will have the constant twitching movement of the hand, and it is considered as a milkmaid grip. Other are spooning, hyperpronation. So for hyperpronation we have to tell the child to elevate the arms over the uh, above the head, and child will keep the position of hand in the hyperpronation. You can see in this image. And for spooning, we will tell the child to outstretch the hand, and when child will do it, hyperextension of the finger with flexion and dorsal arcing of the wrist occur in the shape of a spoon, and the finger are separated and the thumb is abducted and drooped downward, so considered as a spooning. And for the darting tongue, we will tell the child to protrude the tongue. Child will not be able to protrude the tongue, and child will shoot out and jerk back quickly. And also child will have the movements just like a piano playing. So all these are the characteristic of the chorea. There are various etiology of the chorea. Commonly we see the syndendum chorea due to the rheumatic fever, also known as St. Vitus dance. Other etiology, it can be seen in some autoimmune disorder, example SLE, antiphospholipid syndrome, Behçet disease. Also in endocrine disorder, example hyperthyroidism, even in some infection, neurosyphilis, HIV, even with the some inborn error of metabolism, example non-ketotic hyperglycemia. It can be seen because of the basal ganglia lesion, example infarct, trauma, tumor, and other causes can be some drugs can lead to the chorea, example levodopa, phenytoin, lithium, even the isoniazid, cocaine, and OCP. And other inborn error of metabolism in which the chorea will be the finding, example in Niemann-Pick disease and neuroacanthosis, Lesch-Nyhan syndrome. So there are various other etiology. Now athetosis. To describe the athetosis, we can say it is the slower, more sustained, large amplitude and irregular course movement. So according to location, it is generally unilateral, but sometimes bilateral. We label as a double athetosis. Its distribution commonly involve the distal parts, and fingers, hands and toes generally involved, but sometimes face, neck, trunk can also be involved. And it is somewhat rhythmic, irregular movement, writhing and squirming character. It is slower and sustained compared to the chorea, and amplitude it is large and coarse, and generally we see the overflow phenomena, that means it is intensified with the activity and also disappear with the sleep, similar to the chorea. And whenever patient is having the athetosis, we can label as a hemode disease. And the movements of the athetosis, there will be the combination of flexion, extension, adduction, pronation, supination, and alternate degree of the movements will be there. Child will flow the body part in a very random manner. Direction will be changed randomly, and affected limbs are in the constant motion. So athetosis meaning means without any fixed position. Child will change the position of the uh, extremities which are involved, and sometimes there will be hyperextension of the finger and wrist occur, and pronation of the forearms, and it will alternate with the full flexion of the finger, wrist and supination of forearm. And sometimes child will also have the facial grimacing, and it will be slower sustained than the chorea, and sometimes it may be associated with the other body parts movement. Now the etiology of athetosis, generally it is congenital, seen due to the perinatal injury to the basal ganglia, and athetotic CP is due to pathological changes in the caudate and the putamen. Double athetosis associated with the status marmoratus of the basal ganglia due to anoxic birth injury. We label the pseudoathetosis or sensory athetosis whenever the patient is having the same type of the movement due to the loss of position sense as seen in the parietal lobe lesion or peripheral injuries. Example in the tabes dorsalis, in which the peripheral nerve disease is there. In these condition, abnormal movement will be more marked when the eyes will be closed. So patient will have the more abnormal movement when the having the no sense of position. So we have to tell the child to close the eyes. Whenever child is having both characteristic pattern of the movements, chorea and the athetosis, we label as a choreo-athetosis movement. In this video, you can see the child is having the abnormal movement of the distal extremities of the upper limb and the lower limb, also having the twitching of the face. Child is having the combination of the chorea and athetosis, label as a choreo-athetosis. Now dystonia. To describe the dystonia, these are the spontaneous, involuntary, sustained muscle contraction which will force the affected part of the body into the abnormal movement, posture or spasm. So according to the location, it can be generalized, focal or multifocal. Distribution generally affect the neck, trunk, and sometimes extremities, face, eyelids or even the vocal cord can be affected. And according to the pattern, involuntary muscle contraction will be there. So the body part either will be in the abnormal movements or posture. It is sustained, slow, cramp-like movement. If the duration is less than 1 second, we will label as a dystonic spasm. If between 4 to 5 seconds, we will label as a dystonic movements. If 4 minutes, we will label as a dystonic posture. And if it occur with the voluntary movements, we will label as a action dystonia. In this image, you can see the child is having dystonia of the neck, labeled as a retrocollis. Extension movements are there, and also having the facial dystonia and also the truncal dystonia. There are various etiology of the dystonia. It can be drug induced as seen in the cimetidine, anticonvulsant, calcium channel blockers. And one condition, DMD, dystonia musculorum deformis. It is a idiopathic condition labeled as a idiopathic torsion dystonia, which is the rare progressive disease seen in the children's. And patient of the Wilson disease, acquired hepatocerebellar degenerative disorder, one inborn error of metabolism in which child will have the dopa responsive dystonia known as Segawa disease. It is characteristically have the diurnal variation in the severity, and also patient will respond to the dose of levodopa. If the patient is having the lesion in the striatum, it will lead to the hemidystonia of the contralateral side. Now the task specific dystonia we label whenever patient is having the some particular activity and developing the dystonia. Example, writer's cramp, in which patient will have the focal dystonia of hand and the forearm. And blepharospasm, upper facial dystonia, in which involuntary closure of both eyes occur. Belly dancer dystonia, it is because of the uh, dance, patient will have the abdominal musculature dystonia. There are various other task specific dystonia. Now the bellismus, it is characteristically wild flinging movements. It involves the one side of the body, then we label as a hemibellismus. If it involves the bilateral, bibellismus or parabellismus. Characteristically, proximal portion of extremities will be involved. It is spare the face and trunks. It will not involve the face and trunk. It is continuous swinging, rolling, throwing movements. It is forceful. It disappears with the deep sleep. And it is such a forceful, patient can throw the things, whatever in hands. That's why it is labeled as a throwing movement. And etiology of the bellismus, infarcts or hemorrhage in the contralateral subthalamic nucleus will lead to the hemibellismus, and patient will have the such kind of violent movement during activity, but it will disappear during the sleep, so we can easily differentiate it. Another abnormal movement is tics. It is a very common condition in children. To define the tic, Either we label as a simple motor tics if the patient is having simple movement, example shoulder shrugging, eye blinking, facial twitching. We label the complex tics if the patient is having vocal tics, having some abnormal vocalization in the form of throat clearing or some bizarre vocalization. It is repetitive and non-rhythmic. It can be sudden or fast, and it disappears during the sleep. Voluntarily, child can suppress it. But whenever child will suppress it, child will have the more anxiety, more tension during this time, and also will have the desire to elicit this movement, but child can suppress. So we can easily differentiate. Tics can be suppressed by voluntary and other movements cannot be suppressed by the child. It is exaggerated with the emotional strain and the tension. Now the last abnormal movement which I am going to describe is the myoclonus. According to the location, it commonly involves symmetrically extremities and the trunk symmetrically. So the patient will have the bilateral abnormal movement. It is not unilateral. Rarely face, jaw, tongue, pharynx, larynx can also be involved. And according to the distribution, uh, some portion or group of the muscle involved symmetrically on both sides of the body. It is arrhythmic. It is rapid, abrupt, brief, jerky, just like a shock-like condition, lightning movement. And sometimes it is too weak or sometimes violent, and relationship to the activity with resting or activity it can be present. It is exaggerated by the some emotional, visual, tactile, auditory stimuli, and the one of the common example in pediatric patient is infantile spasm for the myoclonus. Myoclonus can be epileptic or non-epileptic. It can be simple, complex. So I'm not going into the detail of myoclonus movements right now. In this video, you can see the child is having the abnormal movement of the palate, pharynx and lips. It is the palatal myoclonus due to central tegmentum lesion or inferior olivary nucleus lesion. Now the last part of the motor system examination is the coordination. So coordination of the movements is the function of the cerebellum, and we can assess all the tests whenever the age of the child is more than 6 years. Not possible in less than 6 years age group, and coordination can't be tested if the muscle power is less than grade 3. So what are the various coordination tests? In upper limb, finger nose test, rebound test, dysdiadokinesia, handwriting test. In lower limb, heel shin test, cerebellar ataxia, Romberg sign, tandem walking, walk around chair. Details of all these tests I will cover in cerebellar function assessment. Thank you so much. If you are having any query, you can put into the comment box.